Number one, strategies for collecting. Oh, sorry, go ahead.
Excuse me. I would at this time. Now I would like to turn the meeting over to Ms. Susan Hayashi. You may begin.
Thank you. Sorry, jumped right into it. Excited to have everyone here today. So we'd like to invite and welcome you to the webinar number one, the strategies for collecting required reporting data for program evaluation. Our first speaker is going to be Hae-Young Park, and so I'm going to turn it over to her for some introductory remarks. And so Hae-Young.
Thank you, Susan. Hi, everyone. My name is Hae-Young Park. On behalf of HRSA's Maternal and Child Health Bureau, wanted to welcome you all to the first in a series of evaluation capacity building webinars for HRSA's pediatric mental health care access, as well as the screening and treatment for maternal depression programs, which are supported through the 21st Century Cures Act. Today, we will be discussing strategies for collecting required reporting data for program evaluation. Wanted to take a brief moment to thank our JBS team for all the planning work and for organizing today's first webinar on evaluation capacity building. We're so fortunate to have Dr. John Strauss, founding director of the Massachusetts Child Psychiatry Access Program, known as MCPAP, speaking on this topic, as well as presentations from two of our awardees, one from each of the program areas, the Wisconsin Pediatric Mental Health Care Access Program and the North Carolina Screening and Treatment for Maternal Depression program. So wanted to thank our speakers, Dr. John Strauss for joining us and for sharing his knowledge and experience in this area, and also to thank our two program areas for joining us as well, and all the work that they did in preparing and presenting today. We are looking forward to hearing the presentations and to hearing the comments in the question and answer session to follow. So again, wanted to welcome you all today and thank you for joining us. I will now turn this webinar over to Susan Hayashi to provide a welcome and some brief housekeeping information. Thank you.
Thank you, Hae-Young. And for those of you who aren't familiar with me, I am the project director for the HRSA MCHB evaluation contract. We have really enjoyed working with all of you on this effort. And the overarching aim of the HRSA 21st Century Cures Act program is to increase identification of behavioral health conditions by screening specified populations, children, adolescents, young adults, pregnant and postpartum women, especially those in rural and isolated and underserved areas, and providing clinical behavioral consultation, care coordination, and training to healthcare providers, and with the overall goal of increasing access to clinical interventions, including by telehealth. We are happy to have you join us today for this first in a series of 4 evaluation capacity building webinars that will be held for this project this year. The next ones will be in May, June, and July. And additional evaluation capacity building opportunities will be available in subsequent years. This webinar series is designed to provide you with information aimed at building capacity to design and implement your evaluations. They will address evaluation topic areas and concepts of relevance to HRSA 21st Century Cures Act awardees. Before I get started, I'm going to provide some housekeeping details regarding webinar logistics. For today's call, the roll call, please enter your state and your name. And so for your program name, so that's PMHCA for the Pediatric Mental Health Program, and MDRBD, MDRBD, which is for the Maternal Depression Program, into the chat box located at the bottom right side of the screen and push send. This is, just a way that we can more quickly take roll call without interrupting the presentation. We are going to ask that you hold your questions regarding the presentation until the end, when we'll have a question and answer session, and the operator will step in and give us instructions for that. If you are having technical difficulties during the webinar, please use the chat box for assistance. Type your question into the chat box and push send, and our IT support will assist you as soon as possible. Today's meeting is being audio recorded. Once the recording is available, HRSA will send a downloadable link and a copy of the webinar slides and related materials to all awardees. Okay. So at this point, I'm going to talk a little bit about the HRSA required reporting. Okay. The focus of today's presentation is on the evaluation design, and we talked a little bit about that on the February 5th webinar, and then I've had the opportunity to speak with each of the PMHCA and MDRBD awardees over the course of the month of March. And I've got to say, it's been a real pleasure to speak with all of you. We've learned so much about the programs. We were talking with HRSA this week during our regular call with them and saying it's truly an impressive program that's been put together, and it's a credit to all of the efforts that you're making. And you know, I feel like when I hear what you're implementing, it just makes, to me, the evaluation so important to make sure the nuances and that we're able to capture what's being accomplished through this effort. So just want to say thank you for all the time that you spent with us. So based on what we shared in February, we discussed the outcome and net impact evaluations and the requirements to provide HRSA required reporting data listed on the slide at the provider level for the evaluation. In response to information we learned during the calls with you, we are refining our proposed evaluation design to address the potential challenges in providing us with provider-level data for the evaluation. So as we discussed during our calls, we'll be in touch regarding any further refinements to the evaluation design, as well as next steps for participating in the HRSA MCHB evaluation. For the purposes of today's discussion, we wanted to list these HRSA-required reporting elements as Dr. John Strauss will discuss potential strategies for collecting HRSA-required reporting data to support the program evaluation, and the members of the Wisconsin PMHCA team and the North Carolina MDRBD team will describe their data collection and reporting strategies to collect these required data. So I would now like to introduce Dr. John Strauss. Dr. Strauss is the founding director of the Massachusetts Child Psychiatry Access Program. I think many of you are familiar with the MCPAP program. And he is, this was the first statewide program designed to address the shortage of child psychiatrists. Dr. Strauss was responsible for the expansion of MCPAP to include the MCPAP for Moms to address potential depression, mental illness, and substance use in maternal population. MCPAP are the models for the implementation of access programs in 32 other states and the federal legislation in the 21st Century Cures Act, which has led to the current HRSA cooperative agreements. He is president of the National Network of Child Psychiatry Access Programs, a nonprofit dedicated to providing technical assistance and support to child psychiatry access programs. Beginning in 2019, Dr. Strauss designed the Massachusetts Consultation Service for Treatment of Addiction and Pain to assist adult primary care providers with substance use disorder and chronic pain issues. Dr. Strauss is a pediatrician, having been in primary care practice for 22 years. He completed medical school at Columbia University, pediatric training at Strong Memorial Hospital at the University of Rochester, and was a Robert Wood Johnson Clinical Scholar at Johns Hopkins Medical School. I'm pleased to present to you Dr. John Strauss.
Thank you, Susan. Those are kind words. And thanks to HRSA for all their support of these programs, and thanks to you, everyone on the call, for all the hard work. It's nice to hear Susan report how much you've already begun to do. And I know over the years met a number of you, and I just want to say at the outset that please never hesitate to email, call me, whatever, if I can be of help. MCPAP is now in its 15th year, so we've got a few lessons learned under our belt. So with that, I'm going to start using, for this talk, I'm going to use lessons we've learned from both MCPAP and MCPAP for Moms, and talk to you about the data elements and the way we've collected data. And hopefully that'll be helpful to you as you design your own systems. So one of the important things first is to keep in mind the goal of these programs. And it's to reach the entire population of your program for both kids or moms. And I'll try and be equal to the kids and the moms during this discussion, though sometimes we'll be on one or the other. We're going to reach that entire population of kids and moms through their through the practices and providers that they go to, being the primary care providers with kids and the obstetric providers with moms, and also pediatricians, pediatric providers in terms of postpartum. So we want to reach the entire population so we can have an effect on the entire population of providers, so we have the effect on the entire population of kids and moms. And our belief is that if we enroll all the providers and they're using the program, then their clinical care, whether that's screening, treatment, or referral, will follow. And we're collecting data to see that that happens and that we're making progress towards our goals. And I really urge you, I know all the reporting that HRSA is asking you is daunting, but the real important part of having that data is really to use the data yourself and to monitor how is your program reaching the population and how are providers using your services. So I'm going to start off with a few examples, and then we'll get down to how we collect the data. So we said we want to reach all practices. So we want to follow and track the growth enrollment. In this case, I'm going to use obstetric practices, where the numerator is the enrolled practices, the denominator is all the obstetric practices in your area, and we have a target. We should have a target, and we use 80% in the first 3 years. And even though we don't have quite all the practices enrolled at that rate, we do have the deliveries, which is probably more important. We have 72,000 deliveries in our state, and we know that we're covering the obstetric practices of at least 81%. And for the obstetricians, collecting the denominator is relatively easy, because you can go to those usually a limited number of birthing hospitals, and you go and they can tell you who the obstetric practices are that are delivering. For the kids, you're going to find it harder to get a list of all the pediatric practices that include both those that have pediatricians as well as family medicine. So once we have all the practices, we then want to make sure that the providers within those practices are using our services. And we keep track of that by looking at the numerator, which is the number of practices and providers using our program at least once in the past 12 months. We do that on a rolling basis. And the denominator is the total of either enrolled practices or providers. And our target, 80% of practices and 50% of providers. And we were actually, for a while, above 80%. We've come down a little bit. This is current data, because there are some practices now, after 15 years, are feeling pretty comfortable and don't call us as much as they did. And we still are getting calls from 55% of pediatricians. And then the tougher nugget to crack is looking at what's our effect on the population of kids and moms, and that requires state-level data in general. And we've done that with screening for kids, where the numerator is a claim for a behavioral health screen, and the denominator is all the kids getting well child visits, and our target is 80%, and right now we're running at about, for Medicaid, at about 78%. I'll talk a little bit more about Medicaid and commercial later on. This has taken a good bit of work because we didn't have claims for behavioral health screens, and the state had to implement a code and get that in their database, and it's been a significant lift for the state Medicaid program. And I think you'll find that similar issues as you go along trying to get state-level data. Okay, as you begin to figure out ways to collect the data, and if you have all the data that I've mentioned here, I think you can crosswalk that for pretty much all the HRSA measures. The data is going to be collected. You're going to collect some data that's really just what you're doing as a program, and then you're going to collect some data that's at the practice and provider level, and then what we call the encounter level, and I'll define that a little bit more in a minute. Then you can collect survey data, state population data, and then eventually there are going to be some other potential sources. I think it's eventually, maybe some of you will be able to do it sooner, through electronic health records to get clinical outcomes. So I'm going to go now through each of these to give you some more detail. Before I go to each level, just a visual that everything's sort of tied together. We put it in a triangle. So our main focus is on the practice and the providers, but we're going to be doing training that are aimed at the practice providers, but also they're going to be a service at times to individual providers. Encounters are services, and we'll talk more about what those are, to both maybe training or back to the practice. And keeping track of how these interrelate is really important. As I gave in the previous example, where we said how many practices and providers are using your services over the last year. Okay, first at the program level, the kind of data that you would be collecting would be trainings, whether using a Project Echo model or other Learning Collaborative or other means. And again, you want to just collect how many you're doing as a program, but you also want to know where those are, what audience you've had for those. Webinars, toolkits, you're welcome to look at our website, both MCPAP.org and MCPAPformoms.org, to see our examples of toolkits and other training materials. You may well have a website, and you can look at hits on the website, and then you're going to have a resource and referral database of some kind, and you can measure how extensive that is and how it covers your geography. Practice and provider level. So we're going to have a way of collecting all the information about the practices that I use the word enrolled. Enrolled is a very loose word. We actually do have the practice assign a document that sort of says what each of our responsibilities are, but you don't need to. But the important thing about this is that each practice knows that you exist and knows how to use it, and that you've met with the providers in some way. That may be video, but that you've had contact with that practice and the providers within the practice, so that they're comfortable. This is a real relationship building process, so that they're comfortable using your services and they know you. You really are going to become a coach and a mentor to them. I think some of you who have programs who are expanding programs know that already. And you're going to keep track of the type of practice, pediatric, family medicine, community health clinic, group, multi-specialty, solo, the location, particularly that's obviously a huge concern to HRSA, that you know which of your practices are rural. And the temptation is to quickly sign up the practices that are in the urban areas, that are bigger and more organized and tend to enroll easier, but it's what you really want to look at is that you're getting your rural practices. Insurance, to know a little bit about the practices in terms of the percent Medicaid and commercial. Contact information, something about you want to know who are the actual providers in the practice, both for the kids, PCPs, and nurse practitioners and PAs, and for the OBs, midwives, and obstetricians, and really encourage you to collect not only the type of provider, but also their FTEs. Both these provider types tend to have a number of part-time folks, and you can, if you know how many FTEs there are, you can help you judge how much activity you should expect from the practice. A practice has 2 or 3 FTEs is not going to have the same activity with you as a practice that has 10, 12, 15, whatever. Behavioral health co-location. More and more times we're seeing, not as much in OB yet, but certainly in pediatrics where primary care practice are becoming patient-centered medical homes. Many of them have co-located behavioral health clinicians. So you want to know about them. You want them to feel comfortable calling you. Oftentimes they'll call you and say, I got this kid, this situation or this child, and I'm not quite sure whether they're ready for medicine. We really actually, if you get calls from them, if they can bring in their doctor and you can have a 3-way call, that's even better, because then you can all be on the same page. So you can have like a case conference. And then we do keep track of enrollment status, because obviously everyone starts out active, but over time some practices will close, some will not be enrolled, and you can keep track of that as you continue to reach out to them, and then you get occasional practice that actually refuses. Okay, encounter level. Encounter level is really we use the word encounter to mean any time, any interaction between the practice and the provider and the team. And we link all our encounter data to the practice provider, because we want to look at how the spread of our program is to the various practices in the state. And the kind of data elements we collect, we do collect patient identification, just name and age, and we urge you to do that, because if you collect it, then when someone calls back about the same patient, you'll have some information about what you've done before. Some people have felt that that would be a HIPAA violation, so we've asked it would be a HIPAA violation, I guess, so we've asked the folks in the obstetric and primary care practices to just check with their family to make sure that it's okay. And that hasn't been really an issue, and very few people have refused. But we do have a mechanism, and you should make sure your data system has that, to put in a patient without identification. We do put in just the age. We don't put in the name. We collect, obviously, the practice and the provider calling or being involved in the training. And this is really a good proxy for whether it's a rural service or not. And then patient insurance, we keep track of whether it's Medicaid or commercial. We actually keep track of the specific health plan because in our state we have now gotten so we're funding the program, and as you think about sustainability, really recommend this. We fund the program. The legislature has passed legislation that requires each insurer in the state to pay their share of the cost of the program. And we run about 55 to 60% commercial and the rest Medicaid. We collect the staff person who is doing the encounter, the type of activity and the categories we use: phone consultation, referral, face-to-face visit, televisit, case review, and training. And you'll come up with your own categories. There's no set way of doing this. And then we like to collect the type of visit, which is really the reason for the encounter, and for the OBs, the stage of pregnancy. Screening tools used and the score, and then outcome. And for outcome, we really mean thinking back about the purpose of this program is to build up the capacity of the primary care and OB world to take care of most of the problems, because they're, we believe, mild to moderate and can be managed at the medical level by the and prescriber level by the primary care or OB. And many folks, because this is behavioral health, they're going to need counseling. That should be almost universal. But in terms of who is doing the diagnosing and managing the case and doing any prescribing, we expect that to primarily be with the PCP. So the outcome is whether or not it's with the PCP or somebody else, and or a specialist. And we run 60 to 70% of our calls. The outcome is with where the care remains with the PCP, and that may be the outcome about for the moms about 10% of the time. For the kids, about 20% of the time, we will do a face-to-face, usually one-time consultation, whether that's in person or by televideo, to help with supporting the PCP in the care that they're giving. We keep track of diagnosis, medication, and then we write a clinical note. And the clinical note reminds me that, again, it's useful, as I mentioned, if the doc calls back again, provider calls back again to ask about the same patient. But also, just a note that we've had no medical legal issues, because these kind of encounters where you're giving a consultation over the phone are a type of what's been in the past known as a curbside consult, and there's no doctor-patient, because you're not talking to the patient, there's no doctor-patient relationship established, and therefore not a medical legal risk. Anybody can get sued, but they're not going to have much luck winning anything from you. And but of course, if you see someone in person, then that becomes a regular visit and needs to be treated as such, even if it's by televideo. Then survey. Really urge you to do a pre and post survey for providers. I know that you're going to be doing some in some areas. We'll be able to do some looking at a comparison geography, but the best measure of how you're doing is measuring pre and post. And obviously you can only do you only do pre once, so after you've done your post, then it becomes a sort of an annual survey. And we do annual surveys. Some programs will survey at each encounter. Those tend to be fairly satisfied visits because the person's just been helped. So we think we get better results and more helpful results by doing an annual survey when the provider has little distance from the most recent call. Satisfaction with, so you're measuring the satisfaction with the program, their perception of access now that they can do much more, and they have our help with finding resources, and you're measuring perception of access at the mild to moderate level, at the more complex, severe level, and then for counseling. And then competency, self-efficacy, you can measure that on the survey around treating the mild and moderate, depression, anxiety, substance use, and for the kids, ADHD. The kinds of things that we want folks to be able to do in either the primary care setting or the obstetric setting. And then as we get to the state and population level, so we can look a little bit more at clinical outcomes, we're looking across claims, and generally you're going to be able to more easily do that with Medicaid. And it's the nice thing about both kids and obstetric practices is there aren't too many practices, either pediatric or obstetric, that don't have a significant portion of Medicaid patients. So we've felt, and we've looked at this, that if they're doing well with Medicaid folks, they're probably doing well with the commercial folks as well. In Massachusetts, we do have an all-payer claim database. It's a struggle to get some of the information out of it we'd like, but we hope that we can do more with that over time. We've only had that for a couple of years, but some of you may have that function working well. So what are you getting? What information are you going to collect at the state and state level, or your geography, whatever it happens to be? Screening. You want to know screening per well child visit, screens per delivery, and the percent positive. For delivery, our standard is that we want 2 screens prenatally and 4 screens postpartum. So that involves both OB and pediatric, and ideally you can bring that together. That's a challenge, and we're still working to do it across both populations. And then ideally you'd get referral information to make sure that when a screen is positive, there's a follow-up. You'd want to know what diagnoses are being made, where that care is occurring, whether it's occurring at the specialty or the primary care level, and the type of provider who's delivering that care. And then finally, we can think about other potential sources. I'd be interested if anyone is thinking about being able to use electronic health record data. Theoretically, it should be possible, and NCQA and HEDIS, who at the health plan level are really pushing the health plans across the country to begin to collect data directly from electronic health record systems so that you can get clinical outcome. And there's now a HEDIS depression measure that relies on getting PHQ-9 scores over time, and there's going to be next year probably a postpartum depression measure. So, you may be able to get this, but again, it'll be a struggle for most systems to be able to provide you this data. And then in practice, you could review records, and not an easy thing to do without with the resources that I think most of you have with this program. So that's really the end of my presentation. I'm a few minutes early, so hopefully we'll have time for questions at the end. And I really welcome hearing from you, and be glad to answer questions. So, Susan, back to you.
Okay. Thank you so much, John. We really appreciate everything that you've shared, and I think for everyone on the line, that triangle figure is something that at least resonates with me from a data perspective of being able to have the alignment between having patient-provider data that you can track the trainings that they've received and then the encounters, and that becomes the foundational piece for your HRSA reporting. And like we've said, we'll have time for questions and answers at the end. At this point in the agenda, I'd like to introduce Michelle Broadhouse from Wisconsin, the Wisconsin PMHCA program. She is an associate professor in the Department of Psychiatry and Behavioral Medicine at the Medical College of Wisconsin. Her research interests include population-level approaches to improving behavioral health. She leads a large community academic partnership funded by the Advancing of a Healthier Wisconsin Endowment, which supports 10 community coalitions across Wisconsin to enact structural and systems-level strategies to improve key indicators of behavioral health. She has also served as the evaluator for the Wisconsin Child Psychiatry Consultation Program since 2014. And also as program director during its first years of DHS funding, during which time the program expanded to 4 Milwaukee area clinics and to 94 clinics statewide. Welcome, Michelle, and I'll turn it over to you now.
Thank you so much for that introduction and for inviting me to present on our Redcap tracking system. Thank you, Dr. Strauss, for giving such a great overview of the different sorts of data that are helpful or hoped for to receive to evaluate these programs. The Wisconsin CPSP definitely used MCPAP as a model, and having you sort of summarize these different sources of data really makes my job easier so that I can focus more on sort of the lessons that we learned in how to track all of these different data points in a way that is user-friendly, both for the coordinators that interact with the system and do most of the tracking, as well as for myself as the evaluator trying to pull data to answer questions. So with that, I'll get ready. I just wanted to orient people a little bit to the Wisconsin CPSP. So we are an existing program. As the introduction sort of alluded to, we've had DHS funding since 2014. We started even before that with a very small pilot project with 4 clinics in Milwaukee County. And with the DHS funding, we expanded into the southeast region a little bit and also much more into the northern region, which of course is a lot more rural area. And this slide just shows sort of our reach in those 2 areas right now in terms of the clinics that we have enrolled and some utilization records. And you can see in the outline, this is the area, the counties that we are expanding into using the HRSA funds. And we are taking simultaneous implementation and approach. So we are in the process of finding the appropriate staff to take care of this region, and then we will be doing our outreach efforts into the entire region. Some lessons learned just in terms of enrollment before I get to data. We plan to use the similar strategy that we have used before in terms of very targeted outreach to providers using some of the contacts that we already have, including professional societies such as the Wisconsin Academy of Pediatricians and the Wisconsin Family Practice Association. We hosted several stakeholder meetings when we first got DHS funding to answer questions and introduce the program. Something that we have learned is that I'm sure it comes as no surprise that these providers, these clinics are very busy. It remains difficult sometimes to get in, and often the office manager is the gatekeeper to the clinic. If you can get an office manager to really sort of see the value in the program, that is what really helps get in order to enroll a program versus trying to go to individual primary care providers. We identified champions early on and were able to interview them and get some testimonials that we think might have also helped with outreach. And we had to accept that there's sort of a stages of change for primary care providers. Some may be in that stage where they still don't see it to be part of their job purview to take on these mild to moderate mental health issues. So you sort of have to also meet the primary care providers where they are, and that sort of, if we think about it as a stages of change model. We also have done a lot of learning about our data tracking system. As I said, a lot of our initial documentation even was borrowed from the very successful MCPAP model, and then we tailored it to be more to adapt to the Wisconsin-specific context and to the specific questions that we were being asked by our funders. So our encounter form, which I'll talk a little bit about later, which captures all of the information that Dr. Strauss talked about that's important for each encounter, has changed over time, and we think that it has been able to mean that we're capturing more accurately what these consultations really are about. So we see it as a continuous quality improvement opportunity. Every single year we go and sort of do an audit of the encounter form to see what modifications still need to be done. We specifically wanted to get some more information about medication questions. As you can see, medication questions are far and away our sort of largest, the bulk of the questions that we get from our primary care providers, and we wanted to get a little bit more information about, okay, does that mean they're asking questions about starting a new medication? Are they asking questions about the dosage, whether that's increase or decrease? Are we talking about side effects, contraindications? So we wanted to get, like I said, a lot more detail about that medication question, and therefore the questions have slightly changed since 2014. In the original 2014 data system, had some flaws, and so we have a lot of lessons learned from that. At the time, we had a lot of different houses for data in terms of encounters were tracked through Redcap, whereas things like clinic-level data and provider-level data even were tracked using just individual Excel spreadsheets. This also meant that it was extremely tedious to try to connect one data source with another, especially since the way to link them was by provider name, which is, an open-ended variable that, considering the amount of data we were collecting on each encounter may have spelling errors or just differences in how it was entered. So it was a real headache to try to retrieve data about, reach or utilization, since those different data sources were kept in sort of different systems that couldn't talk to each other. So I finally came to the realization that we needed to rebuild the entire Redcap data system. And it took about a year to build, and then we imported our existing data into it. We did a lot of QA. We set up our surveys within the same Redcap system as well, and we did a lot of testing. And I want to just give a shout out to the clinical coordinator for this project, Sarah Hare, who spent a lot of time with me figuring out the best way to make this Redcap system most helpful for the people that use it most of the time. So of course, I would definitely encourage very close collaboration between evaluators and coordinators to really make sure that any data system that you have is understood, user-friendly, and most helpful. But I am proud to say that we were able to roll out the new data system in July 2018, and it's been going really well. I think, still few opportunities for continuous quality improvement. But how it works is there's actually two linked databases. One database that houses all of the clinic level data that's entered by the coordinators. And we track both clinics that have already been enrolled and ones that we sort of are doing outreach to and trying to get enrolled. And we collect information about the clinics in that database. And then we also have linked to that database, we have a provider database that's linked to the clinic database. So it allows us to have a sort of a closed-ended response to, what clinic does this primary care provider belong to. I've highlighted email address because what we have learned is if you want to get any sort of information from primary care providers, if you want to be able to send surveys, the most important thing to have is the correct email address. So we encourage anyone who is answering phone calls for consultation that they confirm the correct email address. We also collect a lot of other information about the providers, things that Dr. Strauss has already referred to in terms of trying to track if they, what we call inactive, including if they've moved, if they're retired, we just can't find them, that we are sort of flagging them. So if they do pop up again, we're able to get that information back from them. Something else I'll talk about a little bit later is we also house the estimated number of patients each provider has, and that's drawn from a payer database that I'll talk a little bit about called WEO. And so also within the same provider database is let me back up one second. We also have an enrollment form that we collect, and the Redcap database allows flexibility to either have it documented in Redcap by our coordinators if, for example, the enrollment form was signed on a piece of paper. We still are able to confirm that we have an enrollment form within Redcap. Or if we're not able, for example, to go and do an in-person enrollment meeting, which we typically try to do, specifically because of, like Dr. Strauss talked about, the importance of that relationship building. So we always try to set up an enrollment meeting to go and meet with all of the providers in a clinic that we're enrolling. But if for some reason that's not possible, it can also be sent directly to the primary care provider's email. And then we also track any encounter that the primary care provider has with us, as well as several surveys that we send to them to their email. I'm not going to go through this, but this is a list of most of the pieces of data that we collect for each encounter. And it's a shared responsibility between the person who triages either the phone call or the email and the actual our CPCP providers to capture both what the reason for the consult was and the outcome of which. We don't collect patient identifying information for various reasons that if it comes up in Q&A, I'm happy to talk about. We do find that often when we do try to check gender, age, insurance, and whether the child is in the foster care system, but that information is often missing. Again, I can talk more in detail if people have more questions about that. Again, I'm not going to read through all of this. You all can, of course, read through this at your leisure once the slides are made available. But we do collect pre and post surveys. They're anonymous. These are the only surveys, the only pieces of data that we don't have connected to our larger Redcap database. And it really is, these are just some examples of the things that we ask on those surveys to estimate the increased capacity for the primary care providers to deal with mental health issues in their pediatric patients. I just wanted to give just a really quick snapshot of what Redcap looks like. As you can see in the sort of center of your screen, those are all the different either data forms or surveys that we collect. Just so you can see, like I said, that it's all connected by provider. It also allows for setting up automated surveys, so you can use Boolean logic to really just determine whether or not, when a provider should get like a satisfaction survey or an introductory survey, so that the coordinators don't have to go in and sort of manually do that, which takes some burden off of them. It's also, Redcap is good for reporting purposes. You can do a lot of reporting. You can do a lot of data retrieval just within Redcap itself. This is just a screenshot of what a simple report would look like if you're interested in the credentials and specialty of the providers we have enrolled. You can also export the any reports that you do into various data software packages, whether it's just simply for Excel. You can also export it into SPSS, which is what I use most of the time, but they also have SAS and R and Stata. And I just wanted to sort of show that this system will allow us to report on most of the required measures and see even some additional measures. Just wanted to give a shout out also to the WEO system, which is an all-payer claims database, which allows us to pull the number of patients each provider has seen in the previous 2 years, which is what we use as a proxy for the population reach. But there are some limitations in terms of that for us in Wisconsin, it does not capture mental health screening well. So that's something that we'll continue to struggle with, but I'd be interested in learning more about those advocacy efforts that were successful in Massachusetts potentially, because that could be very helpful. And then finally, as Dr. Strauss says, I think we very much agree, don't just use the data for reporting purposes. We try to do a lot of dissemination to various community events. We have a lot of swag and posters that we like to go around the state with to really promote the program and get the word out about how it has been helpful for primary care providers and their patients. And I believe that is my time. Sorry I went through that a bit quickly, and of course happy to answer any questions either after this presentation or at any time.
Okay.
Sorry, I just realized I was speaking on mute, so I apologize. Thank you so much, Michelle. Really appreciate everything that you shared, and as she said, that we'll be making the slides available to everyone and to allow you to take a closer look at some of the visual items that she included. I think, so it's very helpful to see your program. And now I'd like to introduce Kendra Rosa and Hannah Rackers. And fortunately, I guess maybe fortunately for this presentation that we could put the Duke-UNC rivalry aside for and showing how great the universities and the state work together. So Kendra Rosa is the Division Administrator for the Division of Child and Family Mental Health and Developmental Neuropsych in Duke University's Department of Psychiatry. She is also the project manager for North Carolina's HRSA-funded PMHCA Access program and is supporting coordination between UNC. Apologize, my screen just went blank.
Let me take over, Susan?
Yeah, that would be great. I just lost my screen.
Sure. Supporting coordination between UNC and Duke for this North Carolina Maternal Mental Health Matters program. Kendra obtained her master's degree in public health from the University of North Carolina's Department of Maternal and Child Health. She has previously worked in program implementation and evaluation for an evidence-based social-emotional skill-building curriculum for parents, children, and teachers. We also have Hannah Rackers, MPH, who is a research instructor in UNC's Center for Women's Mood Disorders. She serves as the program manager for North Carolina's HRSA-funded Maternal Depression and Related Behavioral Disorders program, North Carolina Maternal Mental Health Matters. Hannah obtained her master's degree in public health from the University of North Carolina's Department of Maternal and Child Health. She has previously worked in rural health and program development with organizations providing high-risk and mental health care coordination. So thank you, Hannah and Kendra, and you can take it over.
Great, thank you. This is Hannah to start off with. Thank you for that introduction and this opportunity to learn from everyone who's been doing this already, as we are a new program. So as mentioned, we are a partnership between North Carolina Department of Health and Human Services, University of North Carolina, and Duke. So we are not totally starting from scratch because Duke has also been awarded the PMHCA grant and had a pediatric access line that started about a year ago. And so we are learning from where they've progressed so far and then doing this really as a joint effort between the pediatric side and the perinatal side to approach this with a real maternal and child health effort. So Duke started their pediatric line in 6 rural counties in north central North Carolina. And so the perinatal program is starting in those 6 counties as well to capitalize on provider connections that they've already established with the ped side and then building on it with family medicine and OB. So our plan for phased implementation is to expand to 15 counties over the next 4 years and then develop a plan for statewide sustainability and rollout by the end of the grant in 2023. So for the phased implementation, we're really going to focus on quality improvement efforts at each stage and adapting it as we learn from each county and the diverse geographies and demographics of North Carolina. Additionally, the phased implementation allows us to have a comparison group to compare outcomes and impact for counties and providers in our participating areas to the same measures in counties that are not currently participating. So that's going to be of great value to us and really isolating the impact of the program, though there is some potential for spillover. So in early lessons learned, in addition to what Michelle had pointed out about engaging with providers and things like that, North Carolina has limited existing screening and treatment data sources available. There's claims data, PRAMS data, things that really are getting at maternal mental health in pregnancy and postpartum are fairly limited. So with this, we're hoping to kind of evaluate that landscape and to then establish a baseline for what is the need in these areas. So we also are looking to kind of balance this desire for strong, rich evaluation data and then minimizing the burden on participating practices and providers because we know they are busy and their time is valuable. All right, Kendra, you want to take over?
Yes, hi, this is Kendra. Thank you to everyone who has presented. As Hannah mentioned, we're in this interesting place where in our state where the maternal program is newly funded, and we've had a little bit of a pilot on the pediatric side, but our data collection systems are totally new. So we are working to combine our data collection systems and use the same provider enrollment and data collection for both of our programs, which really gives us the opportunity to streamline our data systems and make enrollment and data collection a little bit less burdensome for our providers who provide care to both moms and children in our state. We'll be using Redcap as well as administrative databases like Microsoft Excel, but primarily Redcap to capture the data that we need for reporting on the HRSA required performance measures. And we intend to collect no personal health identifiers in Redcap. So I think we've heard a couple different models on this call about how to use Redcap versus the medical record for capturing the data. But we will be capturing all provider and practice level data in Redcap, starting with this North Carolina provider master file that we have developed, compiling information and a list of all MDs, DOs, PAs, and NPs, as well as certified nurse midwives who provide primary care services to perinatal and or pediatric populations in our state. And so our goal really is to pull that first into Redcap and have a baseline of our providers in the state, and then branching from that, link all of the provider level data that we'll be collecting, including from welcome surveys and follow-up surveys as well as self-efficacy measures, all at the provider level. In terms of our program level data, we'll be collecting staff tracking and survey information in our administrative database, as well as the training calendar and documentation in our Excel spreadsheet document. And as I mentioned, the clinical documentation will be kept in our Epic medical record system. The patient level data will help to inform our consultation and telehealth provided by our team, as well as shape program implementation and outreach to providers. And finally, in order to examine the impact of our program on screening, treatment, and referral rates, we'll be working with claims data from the North Carolina Medicaid program as well as Blue Cross and Blue Shield of North Carolina, and we'll talk a little bit more about that on the coming slide. So for our program, we really wanted to take a step back, and as I mentioned, we have been compiling this master file with the North Carolina providers. It contains provider name, license type, practice area, clinic name, and address. Michelle mentioned with the Wisconsin program that email addresses are critical, and so in step 2, we'll be reaching out to practices, primarily nurse managers and other practice managers, to obtain those provider email addresses. During the practice outreach phase, we will also collect basic practice information like population characterization, what standard mental health practices they might have in place, as well as their interest in telehealth services for their patients. And finally, once we have provider email addresses, or if we are directly present with a provider, we'll be able to complete a set of forms directly with provider data, including their preferred communication mechanisms, their preferred educational strategies, as well as their the mental health topics that they are most interested in and most relevant for their practice. And in terms of our impact evaluation, Dr. Strauss mentioned the challenges in using claims data, but we are looking forward to using claims data and are hopeful to learn from the lessons in other states to use claims data to establish a baseline number of the target population of women we are interested in for this program, and to assess provider practice and county level patterns in screening, diagnosis, and treatment across the state, as well as variations by county, by demographics, rural versus urban, et cetera. And finally, we intend to use this claims data set to cross-check with our North Carolina provider master file, as well as shape our program in identifying gaps and areas of improvement over time. Okay, and I'll turn it over back to you, Hannah.
All right. So this next slide is just an overall picture of our conceptual model for the program. We're kind of using this as a broad strokes working for lining up our indicators for HRSA performance measures and outcome measures and where they fit in with different stages of the program as far as like things we're actually implementing versus outcomes we'll see versus impacts we may see from the outcomes. So on this right-hand side, I've boxed off those main HRSA measures that we have for the maternal grant for reporting, including provider self-efficacy, participation and consultation, increased screening rates, and then increased rates of treatment and referral for women who screen positive for a behavioral health disorder. And so on this next slide, we have a subset of our indicators that we're planning on monitoring for our program, matched up with our program factors, and then also with some of HRSA's reporting, though not all of it. So for example, with the provider training aspect, we will have attendance logs for trainings and webinars that will be linked to the provider's Redcap record. And so we will know like which providers have attended what training, and then how many providers in a certain practice may have attended trainings or received trainings. And additionally, we'll be recording how many providers received the toolkit and the number of providers accessing the consultation line. And so from the consultation line piece, we'll also be monitoring the encounters and what the content and characteristics of the encounters are, so that we can disaggregate by characteristics that we're interested in, or also potentially by provider specialty or provider practice, for the purposes of monitoring and kind of quality improvement as we implement the program, so that if a certain practice might need more assistance supporting a certain disorder, then we can identify that and maybe tailor our one-on-one training with that practice. Additionally, we'll be monitoring the referrals that result from each encounter and then the course of action that would result from each encounter. And so for our outcome measures, we're kind of splitting the outcomes up conceptually by outcome and impact, because we're directly intervening on training and providing support to primary care providers. So that focuses on the consultation and self-efficacy piece. So we'll be using that self-reported self-efficacy from the surveys, and then also the volume of calls and content of calls to monitor that. And then from that support, we hope to see the increased screening rates and the increased rates of treatment or referral for treatment. So we will be monitoring those through claims data, hopefully, and additionally, we will have for the referral also programmatic data for referrals as well. And so another piece of our program that I know is not part of every program is we're establishing a telepsychiatry clinic, just because there aren't a lot of resources for perinatal specialty treatment in some rural areas of North Carolina. So we'll also be able to directly monitor referrals to the telepsychiatry clinic in addition to community sources. All right.
In addition to the required HRSA reporting, for our program also use the evaluation data to facilitate learning so that we can continually learn from our process and make improvements to our program to really identify gaps in the continuum of care, to continually improve patient outcomes, really hone in on areas in which the providers in our state need education and additional support. And then there's the dissemination piece as well, really publishing results about this model and sharing information about how the program is evolving, as well as informing sustainability, program expansion, and policy advocacy. Thank you.
Okay. Thank you so much, Hannah and Kendra. I really appreciate everything that you've shared here. And I can't believe we're a little over an hour already with all the nice information that's been shared. So thank everyone. I would like to thank everyone for making the presentations today. At this point, we'd like to open up the lines. I'm going to turn it to the operator because it's time for question and answers now.
Thank you. We will now begin our question and answer session. If you'd like to ask a question, please press star 1. Please unmute your phone and record your name slowly and clearly when prompted. Your name is required to introduce your question. Again, that is star 1 if you'd like to ask a question. One moment, please.
So we'll wait as the questions come in, and we'll also be able to, I think, primarily do it that way, but if something comes in over the chat, we'll be able to answer that as well. So feel free to write in a question if you have anything. Maybe while we're waiting, would you like to address the question in the chat box, Amanda?
Sure, sounds great. We have a question about North Carolina using Epic EMR for patient-level data. And the question is, are all clinics in the 6-county pilot on that system? And Hannah and Kendra, let us know if you would like us to refer back to your slides at any point.
Sure, thank you. This is Kendra. And so the question was if the counties have access to the medical record system?
It is, are all clinics in the 6-county pilot on that system, on the Epic EMR system?
Okay, yes, those clinics are not in Duke's electronic medical record system, but one of our goals through this expansion, through the HRSA grants, is to give clinics the option to join this thing called MedLink, in which case they would have the option to have limited access to the medical record system in order to help facilitate communication about patient care. But it is optional. And in terms of our clinics in the 6-county area, I think there are a few who have MedLink, and most of them are not currently enrolled in that process.
Yeah, and this is Hannah. In addition, I know UNC will be providing a lot of the consultation on the perinatal side, and so we use Epic as well, and there is some sharing through Care Everywhere, but also referring back to Kendra's answer as the main priority.
Great, thank you. We also have a chat question for Dr. Broaddus. It says, could Dr. Broaddus address some of the strategies used to engage practice managers in your project?
Sure. Just in terms of a point of clarity, I'll be speaking on behalf of my my colleague coordinator, Sarah here. So she might be emailing me as we speak as well, some ideas. But I think it was sort of a gradual process. When we very first started expansion, we started with sort of the low-hanging fruit in terms of clinics that were associated with the Medical College of Wisconsin system. So there was it was a lot easier to get that original buy-in. I think also the use of the provider champions was very helpful. We identified, I think, 4 or 5 in the Milwaukee area and maybe 3 in the northern Wisconsin area who we asked to sort of spread the word amongst their colleagues. I think that also helped. Basic outreach in terms of cold calling even sometimes was helpful. Like I said, we have developed a whole slew of informational materials that we have taken to various meetings around the state. We had a really good relationship from the jump with the Wisconsin Academy of Pediatricians, and their executive director did a lot of advertising, for lack of a better word. We had a bit of a slow start doing the same with the Wisconsin Family Physicians Association, but they also are helping spread the word. I'm trying to think what other strategies have been important, but I think those are the ones. And tenacity, for lack of a better term, even if a clinic turns us down, going back to that clinic later, showing them data about here's how the program has helped other clinics like yours, things like that.
Michelle, this is John Strauss. Can I add that one other strategy that we found useful was most practices have a staff meeting, and we would sort of call up and say, when is your staff meeting and who coordinates the agenda on that? And we'd go out to the staff meeting. And it's a good chance, sometimes they want you to talk about something, but it's a good chance to just say, well, think about the last time for kids you had a behavioral health problem, or for moms you had a mom you were worried about their mental health. So it's that kind of one-on-one interaction with the practice is usually very successful. Sometimes hard to get in there to that meeting, but if you keep at it, you usually, they'll give you 15 minutes on the agenda. That's all you need.
And if you offer to bring lunch,
yes,
food always is the great motivator as well.
Nice gooey donuts for breakfast, because oftentimes those meetings are early in the morning.
Great, thank you both. Brittany, our operator, do we have any questions on the line?
At this time, there are no questions on the phone line, but as a reminder, please press star 1.
Okay, great. It looks like we may have another chat question coming our way. Great. So we have a question from Dejon Su for Dr. Strauss. And the question is, could you please explain how you encouraged response to the pre-post survey? Did your team use any incentives to motivate participation?
A good question. Initially, people were excited. The first post survey, we got very good results on. It's been a little more challenging to get annual surveys. I think all of us are surveyed to death. So I'm not sure it helped, but we did offer that anybody who answered them were put into a raffle, and we gave people gift certificates, a couple people gift certificates if they won the raffle. Whether that helped with the return rate, I'm not sure, but I think that it's a struggle, and we don't get super good return rates. But even when we only have a return rate of 30-35%, we get very useful comments. And the people who are most, the people that have issues for one reason or another, often will tell us about it. We get very good comments or some opportunities for improvement, as they say. And I think that one of the things that we've discovered is that people sometimes have an initial bad experience and they don't call you back. So for some reason or another, the phone call, telephone tag or whatever, we haven't gotten back, and they say, well, your service really isn't there. So it really pays to keep reaching out and making sure that there's no glitch in the way the system is working for that individual provider or practice.
This is Michelle. One last thing I'll add, and this is something that has just recently come up when we've talked to our providers specifically about increasing those follow-up survey response rates, is they say, remind us when you send, so we send our surveys through email. They say, remind us in the email, sort of say, like, the reason why we are collecting this data is to ensure the future sustainability of this project so that we are able to continue to provide these services. They say that we've just now put that in place, but they have said that would increase their response rate.
Great idea.
Yeah, really good feedback there. Thank you so much. We have another question on the chat, whether you are all receiving requests for consultation by phone or electronically in some manner. And an additional follow-up to that is, what discipline person is gathering that initial information regarding the reason for the consultation request?
I can answer for Wisconsin that we receive requests both by phone and through a dedicated email address. We get actually quite a few more emails than we do phone calls, partly by design, in terms of allowing our providers time to do the research necessary in terms of the questions. That does mean that some information is missing because we only have the information in the email to go on in order to fill out that encounter form, which is why things like the patient's insurance status, age, is missing. As far as the discipline of the person that takes that initial information, if it's a phone call, it goes to our triage team that is part of the larger triage team for the Medical College of Wisconsin Froedtert Children's Hospital Psychiatry Department. The grant buys out some of that time for them to also do triage for these phone calls. So they are very well versed in the resources and community resources and referrals available in the Wisconsin area. And if it comes through email, it's one of our clinical care coordinators, they have a rotating schedule.
So I'll just point out that there's a big difference between an email to set up an encounter like Michelle mentioned, but as opposed to how you return the information. And especially when you're beginning, our experience has been the nuances that allow a consultant to be a good educator because remember, we're trying to educate the PCP. So it is much easier by phone and talking. So we really try and discourage answering emails. Sometimes it's a follow-up email and they have a simple, concrete question. That's fine. But if it's an initial consultation about a new patient that you haven't talked to them about, it really is so much better to talk to them on the phone. You can find out where they're at, what they're comfortable doing. Otherwise, you just give an answer back that's sort of rote and may not be appropriate for what that doc wants to be able to do or not do. and to really understand, it may be you're going to have docs who've never written an SSRI. Well, you answer that different than the doc. Now, you may know that, and you may be able to answer in the email, but it's pretty hard to know the docs well enough to really figure out what the best action for that encounter is without talking with them. Or you can do emails back and forth, but then you start everybody gets frustrated if you have too many emails back and forth.
That's it. Thank you for making that point. I imagine it often depends on the complexity of the question, whether or not the provider and the provider's sort of time that they have in their day, whether or not it comes in from phone or email.
And sometimes we'll call back and we'll end up, this is really going to be a more complicated discussion. Can I call you back? When can I call you back? If you're
right.
So we're very flexible with the providers in terms of when we call back and how much time we spend with them. And sometimes they're asking very basic questions. It could take more time, and other times it's real straightforward and you answer quickly, and that's it.
Great, thank you both. Just want to check in with the operator again to see if we have any calls on the line or questions on the line.
As a reminder, if you would like to ask a question, please press star 1. We do have one question on the line. One moment.
Great, thank you.
And that question comes from Pam Kelly. Your line is now open.
Hi, everybody. Can you hear me? This is Pam Kelly. I am calling from the New Jersey program. Can everybody hear me?
Yes.
Oh, yes, good. Okay, hi. Yes, hi. First of all, I just want to say this has been such a great webinar. I really appreciate all the presentations. It's fascinating to hear about these other projects, and also really validating in some ways. Here in New Jersey, we have also put together a shared data collection system. It sounds very similar to the Red Hat system and the North Carolina system, and we've also experienced a lot of the same challenges that you were talking about. And I'm sure you also have found this as well. It's so dependent on teamwork, and we've got this really great team in New Jersey. A lot of us have we've known each other for a while. The partners have been working together on various other projects. We're all really committed to this project. So that has so much to do with the success of the data collection. So I can, we all, I'm sure anyone who's an evaluator on this call can really relate to that. But my question is, with regards to the encounter data that you all were talking about, collecting what's happening at the actual patient visits, the level of the encounter, that's been a real challenge for us in New Jersey. And I'm just wondering if any of you all today, we modeled our program on the Massachusetts program as well. By the way, I'm from Massachusetts, and I think it's a wicked good program. But what we're wondering is, over here is, did you have any issues or challenges with getting that encounter level data? I know that, the pediatricians in general or family providers, they're only with patients in the exam room for such a short period of time. So is collecting the information on screening and results of screening and referrals, has that been difficult at all? And if so, what have you done to make it any easier?
Speaking from Wisconsin, Amanda or someone, would you mind bringing up my slide so I can go to the encounter form list of questions? But to answer your question about screening and referral of screening, that is not something that we would ever be able to get from our encounter form. And that's something that we really are anticipating as a challenge for us to get, because the only way to we really can't get really good, like identifiable patient level information that we trust unless we use a third party like an all payer claims database, which I mentioned in Wisconsin has some issues with trying to get both were kids screened and then nothing at all about what happened after they were screened. So I'm afraid I have no answers for you there. And just to be clear, the encounter form is really just about, it's really about the interaction between our CPCP, usually psychiatrist, sometimes a psychologist, but it usually is between what happened between the primary care provider and their interaction with our provider. So what information did the primary care provider give our provider about the patient? What was the question about, and then how did our provider or our psychiatrist or psychologist answer the question to try to understand what the outcome was? And we include what resources or referrals were given, but we have no way of following up to see if those resources or referrals were ever followed up on.
I see. I see.
So,
yeah, go ahead.
So I think you're raising an excellent question, which is a real challenge going to be a challenge for most programs, which is how to get that population data on all the people who don't call you, because we get calls on relatively few kids, thank goodness. And and that really involves around how claims are being collected in your state. And I think someone was asked earlier, well, how did Massachusetts get the screening rate, which we actually, for kids, we know very well. And the answer is, unfortunately, a class action lawsuit against the state. So the state was forced to collect the data. And our program actually was helpful to the state because when they lost the class action lawsuit and had to do all sorts of, give all sorts of care to behavioral health to Medicaid kids, the providers were very happy to have us be able to help them implement that. So it's, therefore we have the claim. And for the moms, the legislature created a postpartum depression commission, and they mandated that the health department have a code, and they developed a unique code so that obstetricians were required to report their screenings. So that doesn't happen overnight, and we're still, the pediatric data was started in 2009, and it's now pretty accurate. The OB data has still got a ways to go. So getting all the systems across all the payers to work is a challenge.
Okay. And this is Susan. I just want to make sure that this question gets answered. I know we're a few minutes over and appreciate the discussion and helpful responses. But John, if you want to finish the response, and then we'll just do a quick wrap-up for everyone. And then we're a couple minutes over time. So go ahead, John.
I think I finished. Was there another question I didn't answer?
Okay. Did that answer your question?
Yeah, it sure did. Thanks so much.
Okay, great. Thanks. I'm just going to check in with the operator real quick. Were there any additional questions on the phone?
We do have one additional question on the phone.
We have one. Okay. It's from HRSA. Is it? Could we take that question yet? If that's possible, if individuals can stay on the line for a couple minutes, would that be okay?
And that's fine with HRSA.
Okay, thank you so much. The operator, please put that question through, and then just so everyone knows, we're putting some information in the chat box if you have to go and for follow-up. But go ahead with that question. Thank you.
Okay. Our final question comes from Kelly O'Dare. Your line is now open.
Hi there. This is Kelly O'Dare with Florida. Can you hear me?
Yes.
Okay, great. My question is similar to New Jersey's question, but I'm specifically interested in Wisconsin or North Carolina, or really any of the presenters on the call that are working with Medicaid information, and if your state is Medicaid managed care organizations, and if that throws any barriers or challenges into the mix, because we are primarily Medicaid managed care here in Florida. We do have some fee-for-service structure still, but primarily Medicaid. And just trying to learn some lessons or best practices about overcoming some of the data sharing hurdles that are inherent when you're looking at a managed care structure.
Speaking from Wisconsin, we have only just recently been able to start using the WEO data, the all claims payer database, and we decided to go that way rather than trying to get information from Medicaid, just to be more comprehensive. So I don't know if I can really answer your question, unfortunately.
So maybe I can help from up in Massachusetts. We've been in all MCO state for a while, and the state just required the MCOs to do it. They have to report their screening data. Took one line in their annual contract, one change of one line in their annual contract, and it happened. So it's, again, it's the will of the state to do this. And because these are state programs, I would hope that they'd have that will.
And this is Hannah from North Carolina. We are actually at the very beginning stages of Medicaid transformation in North Carolina. And so we're hoping to be proactive in the process to aid in that process, and with that at the forefront of like what we want to advocate for. But yes, that is definitely something that we are going to have to tackle.
Great, thank you all.
Okay. Do we have any additional questions, operator?
No questions on the phone at this time.
Okay, thank you. Just want to ask if HRSA has any closing remarks at this point.
Thank you all very much for the wonderful presentations. Thank you, JBS, for convening us and preparing everything for today. And thank you all for the wonderful discussion and questions. And we look forward to the next webinar. Thank you.
Okay. Thank you so much, Hey Young, and really appreciate our presenters today, as well as all of the awardees from both programs attending today. We look forward to our next webinar, and we'll have that topic out fully next week, and that presentation will be in early May. So thank you so much, and we will be sending a link for our feedback on this webinar. So thank you again, and enjoy the rest of your day.
This now concludes today's conference. All lines may disconnect at this time. Leaders, please stand by for post-conference.
Hi all, this is Amanda. Do we still have HRSA folks, Michelle, John, Hannah, others on the line?
Yes.
Michelle?